Dr. Callie Barrett is a critical care physician with the University Health Network in Toronto. She is a member of the Science Advisory Table Secretariat and the COVID-19 Modeling Collaborative. She joins me now. Dr. Barrett, thank you for your patience. What would you like to say? What should we take away from the latest modeling?
I mean, it's catastrophic. We are unfortunately going to experience, the numbers are locked in for the next 2 weeks, and we are going to experience, unfortunately, what we had predicted since February when the new variants were first identified. And so the healthcare system is now buckling down and going to the trenches to fight sort of the battle of our lifetimes. But beyond 2 weeks, we can still change. And so if there was ever a time for us to really adhere to public health measures and demand from our leaders more effective public health measures, this is the time.
Wow, you paint a serious, bleak picture. I mean, and I know you're not using these words carelessly. Obviously, this is catastrophic. Can you describe what does that catastrophe look like?
You know, Kevin Smith, the CEO of UHN, which is the hospital I work with, sent an email to all employees last night asking everyone to clear their schedules of non-essential meetings, highlighting the fact that this was not the time to test the limits of our productivity, and all of our energy need to be focused on helping the institution address the looming tsunami of COVID-19 patients. We are treating adult patients in some of the world's leading top pediatric hospitals. We are sending patients thousands of kilometers away by helicopter without their consent or the family's consent. We have to do what we have to do. And I think it's almost becoming a reality that the triage scenario, which we all would never, ever want to see come true, may be a reality in the coming weeks. It's devastating. It's absolutely devastating. And so while we're all sort of at the limit of sort of what we can do, and believe you me, the healthcare system is going to do what it can to try to be there for the population of Ontario. We have to do more so that the worst of this pandemic is what we see in 2 weeks. And that's it. And it gets better from there. We have to make sure it gets better from there, because if we don't, the number of lives that will be lost and the number of people who will lose loved ones is going to be unthinkable. You know, there have been 1,372 people admitted to Ontario's ICU since March 1st. And that is 1,372 families whose lives, to some degree, have been decimated over the past several weeks. Some of those people have lived, some of those people have died, and many of those people are still in our ICUs. And there are thousands of people who are going to be admitted to the ICUs over the next month.
Do you have the beds? Do you have the staff? Do you have, like, I mean, I don't know how this works.
No. So additional beds is a lovely gesture, but it does not solve the problem, because it takes a lot more than just a physical bed and an oxygen tube to take care of these patients. It is an incredibly complex multidisciplinary team that we work in, and it requires highly skilled personnel. And it's wonderful that our colleagues are coming to help us, and they're gladly welcomed, because quite frankly, we'll take any nurse or any physician in our ICU, but there's a lot of oversight, and there's going to be a lot of like on the fly training that's going to have to help in to allow those people to help us out in the way we need. So we'll do our best, and that's what we'll do. But this is like the worst case scenario in terms of how I ever imagined I would be practicing critical care medicine.
That is terrible that you're all in that situation. It's terrible that we're in this situation. Triage, let's talk about that. Because Dr. Williams said, look, I'm just going to get his words here. We need to look at capacity, not just beds, but staff. No one wants a triage system. We don't want to go there, but it is a reality. It is something that could be very real very soon.
Yeah.
What does that mean?
So in sort of broad statements, I mean, I have not seen the most recent triage document, and quite frankly, I'm not sure it's even been completely approved yet. But in broad statements, what it would mean is, let's say I had 2 patients that were in the emergency department who were critically ill, and I had only room to accommodate 1 more. I would be asking a group of independent clinicians to make an assessment on who is most likely to benefit from that ICU bed based on their past medical history, how sick they are at that moment in time. And the person who is most likely to be alive and survive that critical care admission would be the one that gets the bed. And the other one would be offered the full medical care that we could give up to critical care. So it might mean oxygen, antibiotics, medication that would help. But if that patient's not doing well and they're in pain and suffering, we would offer palliative care. And it would mean that there would be people who will die who otherwise would have survived or would have had a higher likelihood of surviving had they gone to critical care. And I can't, this is the second time I've described what a triage scenario would look like to sort of media. I spoke about this last night on a Twitter Spaces event. I can't believe I'm saying these words. I did not go into medical school and become a critical care physician to do this kind of work. And the moral distress that this is going to create for my colleagues and my profession as a whole is people will quit, people will leave, and this is going to be horrific and devastating for us all, but way more horrific for the patients and their families and their friends.
This is a war zone. What you described sounds like a war.
I really can't think of a better analogy. And the really tragic thing is that those in the line of fire are the people who are most vulnerable in our society. So right now, the people getting sick with COVID-19 are not the wealthy people who can work from home who are probably getting vaccinated. The people who are getting sick with COVID-19 are the people who have no choice but to leave their house and expose themselves to the virus at work. And they may or may not have been vaccinated, and they may or may not have the agency and the social capital while they go to work to speak up if they're in an unsafe environment. And when they do get sick, they're probably going home to a very crowded household with multi-generations living in the same building or household. And if they do get sick, the likelihood that they're going to infect everyone that they live with is very high. I took care of a patient this week in the hospital who had COVID-19 and was desperate to leave against medical advice while he was on 100% oxygen because his wife, his wife's mother, and his 6-year-old child all had COVID at home. And he was freaking out that his wife couldn't handle looking after everyone in his family. Entire families are getting sick with this. And it is affecting the most vulnerable in our society. It is infecting those with the least social capital to be able to speak up for themselves, those with the least amount of representation right now in cabinet and in government. And it's completely unmasked the inequities in our society. And I'm angry, and I'm sure you can see the anger in my voice. Yep. It is not the way I ever expected things to happen in this country. I'm going to leave it at that.
I want to just ask you one last question. You brought up government. I mean, you're on the Ontario Science Advice. You give them advice. You told them. You told them that this is where we could be. Why are we here? Did they not listen? What's going on?
I've said before, I think the Premier, and he said this, that he has to consider many different aspects of this pandemic. And I think up until now, the priority has not been fully health and public health. And the priorities of the economy have been prioritized perhaps too strongly. And I do believe that we need to remember as a society that we can help our businesses recover. We will help rebuild our economy. But when you are dead, you are gone forever. And we have to give people the support that they need so that they can protect themselves and their loved ones and everyone they live with. And that includes a whole bunch of different pieces. It includes public health measures such as stay-at-home orders and keeping schools closed while the rate of the disease is too high in the community so that they can be safely open. It involves masking orders, but it also means not forcing people to have to go to work who don't need to go to work. Right now, the only businesses that should be open are those that we need to keep our city functioning and all of us fed. Those are the only things that we should have open right now. And everyone else should be able to stay home and stay safe. We almost need a shelter at home language to this stay-at-home order. We are sheltering at home from this virus. So we need to be able to limit the number of people who are going out. And we know that the concentration of this virus, where the new infections are coming from, are the neighborhoods where there's the majority of low-income, racialized, new immigrants, multi-generational housing, who are our essential workforce. That's why they're all getting infected. It's because there are essential workers right now, and they don't have the privilege that the rest of us do to be able to protect ourselves at home or at work. This virus has unmasked the importance of social determinants of health and the inequities that, when this is all said and done, as a society, we need to look hard at and see how we can fix so that we can all have the same abilities to stay safe.
Dr. Barrett, I appreciate your insight, your time, and I feel the frustration and the anger in your voice, and I think everyone has as well. Appreciate you very much. Thank you.
Thank you. Stay safe.
You too.